This is Pituitary Grand Rounds, an interactive educational program developed and produced by Pituitary World News, featuring doctors and patients in conversations about their cases and the fascinating journeys they embark on as they deal with their conditions.
Hello, and welcome to this episode of Pituitary Grand Rounds. I'm Dr. Blevins of Pituitary World News. I'm a director of the California Center for Pituitary Disorders at the University of California, San Francisco, where I'm a professor of neurological surgery and medicine. In this episode, we'll focus on Cushing's disease. Cushing's disease is a condition where the ACTH-producing cells of the pituitary gland form a tumor. They produce too much ACTH, which drives the adrenal glands to produce too much cortisol. The cortisol, in turn, wreaks havoc on the human body. We're very delighted today to have a special guest with us to discuss this condition. Sloan Hart will join us. She's one of my patients at UCSF who has suffered tremendously from this particular disorder. Let's welcome her to this program. Ms. Hart, thank you so much for joining us today to talk about your Cushing's disease.
Thanks for inviting me. This is exciting.
So I've known you for a number of years now, and I recall from your history that you presented probably about 13 to 14 years ago with a deep vein thrombosis and pulmonary embolism, and then that recurred probably about 7 years ago.
Mm-hmm. Yep.
And we know that patients who have Cushing's disease are at higher risk for deep vein thrombosis. In fact, 10% risk is what's been shown in the literature. What other symptoms and signs were you having at that time?
Oh, geez. So the first DVT happened, in 2011, and I had already gained, I would say, about 110 pounds by then. And I had gone to a doctor because it just didn't seem right. I think I gained it in 10 months or something like that, and I was told I had PCOS, and so she put me on birth control. And so they considered that DVT as provoked, I guess, because the birth control with the weight gain was enough to cause the DVT. The second one was unprovoked.
I see.
And I was still about 110, 120 pounds overweight. My hair had fallen out. I lost about 3/4 of my hair. My skin turned it was almost purple. Do you remember with the blotches and the...
We call that plethora.
Yeah.
Yes.
And I just had lethargy that you can't believe, fatigue, body pain, joints were beginning to go. So yeah, it was gradual, but it was kind of intense because everything did hit. When it did hit, it was sort of extreme.
Some of the things we know about Cushing's is about 10% of patients will have a DVT. And many patients are thought to have polycystic ovary syndrome to begin with. So it's a very common diagnosis ascribed to patients, women in particular, who have Cushing's. That often leads to further delay in the original diagnosis. Yep. The other unique thing about your presentation is that while most people with Cushing's gain weight, many actually have a rapid weight gain in a short period of time, with many patients that I've seen doubling their body weight within a year, as you practically did as well in that setting. Tell us about some of the other symptoms and signs that you had over the ensuing years.
There are many, and unfortunately my memory loss is one of them, so it's kind of hard for me to pull them all together throughout the years, but the most significant had been the fatigue, the lethargy. I just had no energy, and it was, the sedentary life that ensued from that. I just didn't move. And then there was just huge body pain. So why would I move?
Understood.
Yeah.
So the memory loss, that's essential. We know that high cortisol levels can actually damage and kill off the cells in the part of the hippocampus of the brain that cause the formation of memories. And the fatigue is a remarkable problem that patients often have with this disorder. I do recall that you had hypertension, some diabetes,
Right,
and also
right.
hyperlipidemia. When did those come into play?
Those came in early. So there was, I guess, about 6 years when I was not living in California. I was back in Massachusetts, and I was diagnosed with PCOS, and then the diabetes came in, or it was pre-diabetic, I think. Hypertension, I don't remember them talking about lipids at that point, but yes, blood pressure, high cholesterol. I guess that implies high lipids, but basically it was just sort of fat shaming me for 6 years by medical professionals.
It's really unconscionable that would happen.
Yeah, but they're just like, you're fat, go diet and exercise. And it was like, oh, okay, I guess, but that doesn't help. So it was 6 years wasted of just getting worse and getting worse and getting worse, and all my joints decaying and falling apart, and muscle atrophy, that was a big problem. I lost my balance. I lost my ability to be stable. I think it got so bad that I almost got hit by a car because I had a huge gut that dropped down, and I was trying to get across the street, and this car was coming, and as it got closer, I could see he was just texting. He wasn't even looking at the road, and I was trying to cross, and I realized he didn't see me, and he was going to hit me, so I tried to turn around fast, get out of the way, and my stomach pulled me over, and I fell right in front of the car as he looked up, and he just, hair's breadth. So I had a panicolectomy, because they call it the panis, and so they took the whole thing off, 20 pounds chopped off. So, and that was helpful. It was definitely helpful, but, completely unnecessary if I had, just the loss of all of this stuff that just keeps compounding through the years.
Right. So you had a number of years before you were ultimately referred to an endocrinologist, and they really weren't sure about your diagnosis. They gave you all of these individual diagnoses that add up to what we often think of as metabolic syndrome. But when you saw the endocrinologist, they noticed that you had excessive hair growth, that you were Cushingoid.
Yep.
You had some male pattern hair loss,
Yep.
acne, the plethora, which is the reddening of the face, easy bruising and stretch marks, which are all fairly typical of Cushing's
The
syndrome.
buffalo hump.
And the buffalo, so-called
So
buffalo hump.
unattractive. I don't know who named these things. Yeah, that
Yeah,
was
we like to
just,
call it a cervicodorsal fat pad now.
Yeah, but okay. I guess
Can't
buffalo
refer
hump
to
is
patients as buffaloes.
it's just
right?
awful. Yeah.
So interestingly, the endocrinologist didn't think you had Cushing's, even though you really had
Because we were waiting on
Cushing's.
labs.
Right.
Right.
Yes. I wonder if you could go through with us a series of photographs that you provided that illustrate the progression of your physical changes over time.
All right, so that picture was when I was about 11. And I was always told that I was too heavy. And I find it now very interesting looking back. I don't think I'm too heavy in that picture, but was always fat shamed growing up. And I was wondering if I was too heavy as a kid, if that was sort of laying the groundwork. Like, we had a very stressful childhood, or me and my brothers. We had a lot of alcoholism in the family, and I was the oldest. So I was sort of responsible for taking care of my brothers, and the stress levels must have been abnormally high for children. And so I just wonder if that sort of set the stage in my body for what was to come. But this is about, let's see, I was probably in college, maybe in my master's program, and again, still being told I was heavy. I don't really think I look heavy in that picture, but anyway, so that was probably in my late 20s. And this was this is probably 7 months before the PTSD break that I think actually pushed me right into Cushing's. So that's around 34, 38, somewhere in there.
It appears to me that you were actually Cushing weight at that time.
Yeah, could be. Things were kind of unraveling. And then this, this is at my brother's wedding, so that was 2013. So you can see the hair loss. My face is enormous. That was past the weight gain. That's 110 pounds later. And this is a close-up, but this was, almost no hair at this point, and my face had gotten incredibly strange looking.
So these are some of the symptoms and signs of Cushing's disease or even hypercortisolism. We just heard about many of these from Ms. Hart. The weight gain, the central obesity or weight redistribution with the formation of supraclavicular and cervicodorsal fat pads. The muscles become weak and atrophic. The cortisol levels that are elevated often, if you will, tear down muscle tissues. The skin gets thin for some of the same processes that lead to the proximal muscle weakness. There's easy bruising because of the fragility of the blood vessels in the skin. The skin actually stretches, and patients can develop stria that can be pinkish or purplish in nature. Excess androgens produced by the adrenal gland can produce hirsutism, which is excessive hair growth, and acne. And then many patients have mood disorders, anxiety, depression, what we refer to as dysthymia. These are all fairly common. Not all patients have every one of these conditions. Some patients just have one or more, whereas those who've had the disease for a long time will often have all of these in a very severe fashion. There are a number of medical conditions that are associated with hypercortisolism or Cushing's disease or syndrome due to adrenal tumors. These include hypertension, hypokalemia, glucose intolerance, frank diabetes mellitus, osteoporosis, kidney stones, again, depression, anxiety, infections, especially recurrent ones, and deep vein thrombosis, as we learned with Ms. Hart. Many of these illnesses are gateway diagnoses, in other words, the first thing that a patient might have with hypercortisolism, that if you looked close enough, you would find that they had other features consistent with hypercortisolism. So we encourage that patients who present with any one or a combination of these things are evaluated further to see whether they truly have this particular disorder. So I'd mentioned earlier that you saw an endocrinologist. They actually conducted an evaluation to see whether you really truly had Cushing's syndrome. Let's review those laboratory data now.
Okay.
So the ACTH level, and ACTH is produced by the corticotroph cells of the pituitary gland, was elevated at 90 picograms per milliliter. The serum cortisol level was also elevated at 22 micrograms per deciliter. That in itself is not a diagnostic test, but we always like to see what that level would be in a patient suspected of having hypercortisolism. The 24-hour urine cortisol was elevated at 187 micrograms per 24 hours, with normal being up to 45. These studies alone prove the patient has ACTH-dependent hypercortisolism. The physicians who first saw Ms. Hart also checked her late-night salivary cortisol level that was markedly elevated at 0.3 microgram per deciliter, proving that she had loss of the normal diurnal variation of cortisol secretion. They had also confirmed a 1 milligram dexamethasone suppression test, elevation in the cortisol of 15.8 micrograms per deciliter, where normal is less than 1.8 micrograms per deciliter. And her 2-day dexamethasone suppressed cortisol was only 4, where normal would be less than 2 micrograms per deciliter. These results are consistent with the diagnosis of ACTH-dependent hypercortisolism that was fairly profound. Interestingly, these were the original laboratory data obtained about 2 years before she was ultimately referred to me for further evaluation. So, Ms. Hart, when I reviewed these data from many years ago, it was pretty clear to me that you had a diagnosis of hypercortisolism. I call it pathologic hypercortisolism, which basically was ACTH dependent, meaning that it was probably due to a pituitary source. It was pretty straightforward to me. Yet that's not the answer that you received as a result of this test. Why don't you tell us what you were told?
I don't remember them telling me what it was. We just kept going. My PCP, when I moved out to California in 2015, looked at me in 15 minutes and said, I think you have Cushing syndrome, because all of my features were very obvious. But we had to go through years of proving his point. And we went through numerous different specialists. I saw hematologists, I saw oncologists, I saw rheumatoid doctors, everybody trying to rule out, which they did. So we had that out of the way. And then tons of labs that were, I guess, pretty intricate. And so there was just delay after delay after delay. And finally, I got to you and Dr. Kunwar.
By the time you saw us, I looked through your records, and you had undergone testing for Cushing's probably 2 to 3 times a year over a 2-year period. All the tests were the same. They showed that you had persistent elevations in cortisol and persistent elevations in ACTH and failure to suppress with dexamethasone, all of the classic findings of Cushing's. And yet it appeared to me they kept telling you had pseudo-Cushing's and were trying to blame it on your PTSD.
Right, and I do remember
stresses.
them doing lots of MRIs, trying to, because I guess, and correct me if I'm wrong, it's not Cushing's disease until you can find a tumor. And so they kept looking for a tumor and looking for a tumor. And I guess I was told that finally they realized that the MRI is slicing the images every 3 millimeters. And so the 4th time we used a hypersensitive MRI that did it 1 millimeter slices, and we caught it on camera. So then it became Cushing's disease, and everybody went, oh, okay, well, now you've got Cushing's.
And that's when they sent you to us.
Yeah.
I certainly disagreed with their approach to evaluating you over time. One of the things that I noticed is when I looked back at your old MRI studies, I could see the tumor even earlier on, so it was there all along.
Doesn't make me happy.
Well, let's take an opportunity to review your MRI film.
Okay.
This is a coronal slice through the pituitary gland, and it's a slice taken as if we were cutting a loaf of bread, so to speak, the loaf of bread being your head from front to back. And this slice shows the normal pituitary gland, but the arrow points to a tumor that's located in the right side of the gland. There is also enlargement of the pituitary stalk. The significance of this enlargement is not known at the time we were looking at this study and planning for surgery. So Dr. Kunwar agreed with the findings on the MRI and took you to surgery. And at the time of surgery, he found what he thought was a right-sided pituitary tumor. The pathologist evaluated that and confirmed that it's an ACTH-producing pituitary adenoma. I wonder if you would share with us that experience of any jubilation you might have felt being found to have a tumor, and now you have a chance to be cured of this horrible condition that's plagued you for so long.
Yeah, it was, what I remember was Dr. Kunwar coming in shortly after I woke up and telling me that he had gotten the tumor and they were sending it for a pathology report. And so I was pretty psyched, thinking that this was the beginning, because I was told that everything was going to be reversible. Once we got the tumor out, everything would go back to normal. So I guess my expectation was probably pretty high. And then, of course, we found out that he hadn't gotten it all.
Right. So when we see a patient go to surgery for Cushing's, we expect them to have adrenal insufficiency after the surgery, because the tumor is making ACTH, driving the adrenal glands to make cortisol, and the cortisol suppresses the normal ACTH-producing cells. So by the time we get the tumor out, you're left with suppressed ACTH cells that take a long time to start making ACTH again. and patients can have adrenal insufficiency for a number of months, usually an average of about 10 to 12 months after surgery, sometimes up to 2 years. That's our clue that you've been rendered disease-free and that you're cured. Cure rates for small tumors like yours are generally about 95%. For bigger tumors, cure rates are lower depending on the degree of the size and the degree of invasiveness, but on average about 60%. Mm-hmm. But we thought there was going to be a 95% chance you would be cured, but you were not. Yeah. So let's take a look at those laboratory data after surgery, and I'll explain those in greater detail. The postoperative laboratory data showed persistent elevations in ACTH measuring 100 picogram per milliliter and cortisol 27 micrograms per deciliter, as well as a 24-hour urine cortisol at 93 micrograms in a 24-hour period. These results are consistent with residual pituitary tumor causing ACTH-dependent hypercortisolism. Had she been rendered disease-free, the serum cortisol level would have been under 2 micrograms per deciliter, and the ACTH either very low or low normal, and the 24-hour urine cortisol is usually low in these patients as well. So these results confirmed that she had residual tumor after surgery. So we reviewed your MRI films after surgery, and I think that's where the significance of the thickening of your pituitary stalk first became apparent to Dr. Kunwar. And we felt that he had cleaned the tumor bed out, that probably you had tumor involving the pituitary stalk as well, which is unusual. There are pituitary stalk tumors, and some tumors certainly can grow up into the pituitary stalk from the pituitary gland itself. But I think that's why you weren't rendered disease-free. The biochemistry that we just showed indicated that you still had hypercortisolism and we needed to do additional treatments. So our plan was really a two-pronged approach to try to manage your condition. The first was radiotherapy, of a conventional radiotherapy form rather than gamma knife radiosurgery, and then the medical therapy. But let's talk about the radiotherapy. Do you remember undergoing that treatment?
Yeah, that was a trip. They have to make this huge mask. You kind of look like Freddy from Friday the 13th, and it goes over and holds your head. And I went in every single day for 6 weeks. And my understanding was they wanted to do the lowest amount of radiation in the shortest amount of time because it was right near my optic nerve.
Exactly.
And that's why we couldn't do more surgery in the first place to get that other tumor out. It was because it had been moved or metastasized and moved closer to the optic nerve. Am I right on that?
Well, it was up more towards the optic pathways because it was involving the stalk.
Yeah.
And tumors in that area you can't really treat with a gamma knife radiation, so we give you lower doses over an extended period of time rather than high doses in one fraction.
Right, right.
Now the cure rates with that, the long-term cure rates, meaning total control, are probably anywhere between 50 to 85%, depending on what study you read. So we decided that we needed to treat you with medication as well.
3 years went by, I guess, and there was no change with the tumor.
So let me review the different potential medical therapies for hypercortisolism due to Cushing's disease in patients who have either failed surgery or are not candidates for surgery. So when it comes to medical management of hypercortisolism, we are aware of the fact that in this day and age we have 3 particular targets for therapy. The first being the pituitary gland, where we can use drugs such as cabergoline or pasireotide. The second being the adrenal gland, where we can use any one of a number of drugs that can block adrenal cortisol production. They're shown on this slide. And the third being a drug that actually blocks the glucocorticoid receptor known as mifepristone. There are potential future treatments currently under evaluation, and additional molecular targets are being considered as well. So we had a long discussion about the different treatment options for medical management of hypercortisolism, and we settled on a trial of ketoconazole. Ketoconazole is a drug that inhibits the production of cortisol by the adrenal glands and can control the hypercortisolism. In about 65% of patients with Cushing's, about 15% get liver toxicity that's reversible with the medication. So I remember starting you on the medication and being really overjoyed that we were able to normalize your cortisol level. Tell us what you experienced and what happened after that.
The body changed just as dramatically as it had getting all of the symptoms. I felt alive. I felt awake. I wanted to go do something. I wanted I felt like my old self. And unfortunately, my body had so much damage that I could never actually do anything. I just had this surge of vibrancy. So that was really, really astounding for me, and really hopeful that, maybe I could reverse everything. If I lost the weight, if my hair grew back, if, maybe we got knee replacements or something. I don't know. I could do the things that I used to love to do. And then it stopped working.
I recall your cortisol levels rose back to baseline after surgery. So we had achieved control. They went back up. I went up on the dose of the medication. We again achieved control. They went back up. And we basically stair-stepped your medication dose to the highest possible level. Mm-hmm. And we lost the battle with ketoconazole.
I know, I was devastated.
That's not an unusual finding with these medications, because the tumor's driving the adrenal gland. You can block the adrenal gland, and yet the tumor can still overcome that blockade.
Yeah,
And even with the highest doses that I've ever used, we were not able to get control of your hypercortisolism.
Yeah, that was a drag.
So we had to come up with another plan.
Mm-hmm. Yep, and we went to acilidrostat.
Well, let's talk about that medication a moment, and then we'll talk about your clinical history with the treatment.
Okay.
Acilidrostat is an inhibitor of the 11-beta hydroxylase enzyme in the adrenal gland. This particular enzyme is one of the steps in the production of cortisol from cholesterol. In one of the original trials evaluating this drug, 137 patients were treated for 24 weeks. Half of them normalized cortisol secretion. 86% of patients maintained normal cortisol levels in an 8-week study, and 81% had normal levels after 36 weeks on treatment. As is often the case, once the drug gets approved by the Food and Drug Administration, it's used in the community, and physicians gain their own experience depending on their attitudes on how to titrate treatment and the patient population that they're seeing in clinic, which is often different from a study population. In my experience, unreported, I am able to achieve normal cortisol levels in about 90% of patients with this particular medication. There are a number of important side effects of this drug, including prolongation of the long QT interval, or causing a long QT interval. This is something you see on the EKG. That can be a genetic tendency and caused by other medications. So we have to be careful with that in patients who have a genetic prolongation of their QT interval. This drug, if you give too much, can cause adrenal insufficiency. So we have to titrate and find the right balance or the sweet spot for each particular patient. This drug can lead to the production of adrenal androgens, which can cause hair growth on the face in some patients. It can also lead to the production, excess production of precursors prior to the enzyme block, which can act like a mineralocorticoid known as aldosterone and cause a syndrome of apparent mineralocorticoid excess, which can result in worsening hypertension, edema, and also hypokalemia. These side effects are uncommon, but I have seen them in my practice. This drug is indicated by the label approved by the U.S. Food and Drug Administration for the treatment of patients with Cushing's disease who are not candidates for surgery, and for those in whom surgery did not cure their Cushing's disease. Typical therapeutic doses range between 1 milligram twice daily to 30 milligrams twice daily. So as we were transitioning you from ketoconazole to acilidrostat, I have to admit I was very concerned about your health. You did not look well. I was not sure you were going to survive this condition if we couldn't get control. And in my mind, I was thinking if this new drug did not work, you were going to have an adrenalectomy, which in itself can be very dangerous and create a new disease that has to be managed very carefully. So I was excited to have the opportunity to use this drug, which was new at the time. And I think you were probably the first patient I had started on treatment when this drug became approved. Yeah. So we started you out on a dose of medication, and I was surprised that it worked, but you weren't a lot better, so I increased the dose. And we learned some very interesting things about your body during that process, and I think one of them was the concept of what's normal for you. because we have this normal range of urine cortisol that's said to be between 5 and 45 for most labs. A lot of doctors will treat to get a patient in the normal range, but to enable you to feel better, we had to hit a certain level, and I wonder if you could share what we learned during that process of titrating your dose.
Yeah, that was an interesting time because I found out later that not only you were concerned, but the rest of my healthcare team at the time thought I wasn't going to make it. My PCP was very concerned, and my therapist said she thought we were going to start talking about hospice. So it was a really relief when the Silidrostat started working again. But the range for me, we found out, is somewhere around 11. You call it my sweet spot.
Right.
And I'm now learning, because I think other people, they were saying around 20, 18, 20 was supposed to be the good spot, but...
Everybody has their own little normal range.
Yeah.
Some people are going to feel great at 30, other people at 20, some people at 7.
Right.
You seem to feel great
11
around...
is my hot hit.
11.
So, and then I also know that if I go like 2 points higher, I'm back in a danger zone, feeling awful. I start gaining weight, my hair starts falling out, all that kind of stuff again. And if I go 2 points too low, I get the fatigue and the lethargy and the body pain. So I really have to stay right at 11, which...
It is a sweet spot.
we try.
One of the things that I could tell was that when you were not controlled, your face was beet red, especially
almost purple.
Your forehead, and
Yeah.
it was. I could just look at you. At the time, we were doing Zoom through the COVID era.
Yeah.
And I could just look at you and know that your cortisol was higher than it should be. And anytime that was gone, I knew that you were probably right on target.
Yeah.
And it seems to be that matches very well with your sense of well-being.
Yeah.
So you're on Silidrostat now, and what is your current dose of medication? Tell us how you take that medicine and how you've worked that
All right.
therapy into your daily life.
We've had to tweak it a little bit. So I do 1 pill, which is 10 milligrams or 5 milligrams, I can't remember. Anyway, every morning, and then 1 pill every other night. So we're trying to, because I was doing 1 in the morning, 1 in the night every day, and we found out that was too high.
Right.
So we reduced it a little bit, and I actually kind of want to see if we can reduce it again, because I'm beginning to feel like I'm getting too low.
Okay. Tell us some of the things that you noticed that have improved since you started this medication and nailed your cortisol level to around 11 relative to how you felt, say, before you started any medical therapy whatsoever.
Well, I used to, and I actually, when the meds aren't, when I'm too high or too low, actually, I get severe depression. And that's been kind of critical at times. And it hits almost like overnight. It's really scary. But when it is working and I'm on that 11 point, I really just feel like I'm back to life. I mean, I felt, like I was in a coma from 38 to 50. All those years just gone. I was just sick and a lump. And so then all of a sudden, it's like, oh, right, I feel like I'm 34 again. I mean, I was a paramedic, and I was a lifeguard, and, go hiking and stuff. And all of that energy and all of that vibrancy just disappeared. And so that came back. And it just was
good.
Unfortunate that, and then there was a whole bunch of weight loss. That happened. And I didn't do anything. I had been a vegan and a strict vegan for about, I think I did 7 weeks on this program before I was told I had Cushing's, just to see if I could lose the weight, because I still thought it was me. And I think I was eating nothing but like kale and air, and I couldn't lose a pound. When I started losing weight, I was actually in a Weight Watchers program, and I felt really guilty because I wasn't following the program. But I liked the group, so I keep coming. And I was losing like 7 pounds, 9 pounds, 5 pounds a week, every week. And I felt like awful. I'd come in and these women are listening, Sloan gets another pin or whatever it is for losing 10 pounds this week. And it just fell off. It was like my body was purging all of this toxin that had been built up with the disease. And then the minute my cortisol level gets to that point, it's like, phew, let's shed all this stuff. Because I wasn't doing anything different. I couldn't exercise, and I wasn't eating anything different. So it just left.
That's the fascinating thing about Cushing's in that you gain the weight with no changes in activity or
all of a sudden 110 pounds, boom.
And then you lose the weight with the same, no changes in lifestyle whatsoever.
Yeah, no, it was really weird. It was like, this isn't just water that I'm losing, this is actual pounds.
And how about the hypertension, diabetes, and hyperlipidemia?
That all disappeared. I'm no longer diabetic. The hypertension is gone. I probably still have lipid issues just because there is still some weight. But yeah, my PCP was very excited.
How about your mood? Do you feel better?
I do feel, that's that energy, that vivacity. But there are points where if I am off my range, the depression will hit, and it's severe. So that's a concern.
So it's important for us to keep you at your sweet spot.
Yeah, it really is, because I lose all hope. I don't even want to exist. It's not even like I'm worried about suicide. I wish I'd never been born. So it's like past. That is, it's severe. So that's the one thing right now I'm trying to really keep an eye on, in hopes that I can do some. I've got arthritis and losing cartilage. They had to resection my toes.
The unfortunate thing about Cushing's is arthritis tends to get worse when you're cured or treated or controlled. Because high cortisol levels cut down on the inflammation in the joints. So you can see a flare in that. And I've seen patients actually develop severe rheumatoid arthritis after treatment, because the Cushing's was keeping the rheumatism at bay. Yeah,
and then my memory loss and my cognitive capabilities do seem to be declining.
Those unfortunately don't improve much.
No,
they
I
can
know,
improve
and
some. But most people with Cushing still have some mood disorder, dysthymia we call it, anxiety and memory losses, memory problems after successful treatment.
I'm on meds for anxiety. There's still a lot of stuff. There's damage, and I don't think it's going to be reversible. And in fact, it seems like it's still degrading.
Yeah, it's never a full reversal, but certainly improvement in some of the greater things that can affect your health in a negative way, but never full recovery. Yeah. With that in mind, let's talk about the long-term follow-up plan. So as we mentioned earlier, there's a 50 to 85% chance that you'll go in remission from the radiotherapy. Most of those remissions come anywhere between 3 to 7 years later. I've seen them as early as 18 months, but most of the time it's 3 to 7 years or so. So ultimately we have to start discontinuing your medication to see whether or not you're in remission. We can also follow your ACTH level. When that starts to drop, it's time to start taking a look to see whether you're in remission. I'm hopeful that you're going to get there at some point, but we'll continue this medication as long as is required. Hopefully you'll get to the point where you are actually in remission or cured, and then we'll follow you to see if you ever have another disease recurrence over time. Interestingly, patients often know if their disease is controlled or not, or whether it's coming back, because some of the earlier features that they'll have if they've been in remission and it's recurring is that they'll notice insomnia and weight gain. So when a patient tells me that finally they were doing well, but then now finally they can't sleep, or suddenly they can't sleep well, that's when I start testing for recurrence. And we have a number of different tests that we do for recurrence. I'd like to go over some of those now.
Okay.
So when evaluating for possible recurrent disease and sometimes persistent disease, I'm often asked, what are the best tests? And to be frank, I order all the tests that we're going to see on this particular slide, because they're all informative and help me understand what's going on with a particular patient. So we certainly do the overnight 1 milligram dexamethasone suppression test and the late night salivary cortisol levels in all patients. I actually like to do a salivary cortisol profile where I get levels in the morning, the afternoon, and then the evening, because if I see a normal diurnal variation, that patient does not have recurrent disease, whereas recurrence with pathologic cortisol secretion, even in levels that are normal, you'll see loss of that diurnal variation in that setting. I always like to see the 24-hour urine cortisol just to have an idea and to gauge the severity of the pathologic cortisol secretion when that's present. And of course, I like to confirm with the ACTH levels. They're usually normal in patients recurring, but if they're elevated, that lets you know that there may be significant growth of the tumor, and certainly you would proceed with an MRI in those patients or in a patient with any significant abnormalities in any of these tests. So my hope is that we actually get to a point where we're worrying about these tests for you, that we can see you go into remission and then have to do these periodic surveillance studies to see whether or not you ultimately develop a recurrence after achieving remission following radiotherapy. Is there anything that we haven't touched on today that you would like to share with us?
I have a suspicion, and you probably do too, that this isn't such a rare disease. It just goes underdiagnosed. I mean, I go into stores and I see women, and I kind of want to go up and say, hey, listen, have you talked to your doctor or seen an endocrinologist? Because total exact replicant of what I was. So I hope that this helps bring more light to this disease, because it's devastating. It's awful. It's ruined my life. I've lost just huge amount of years, and it's eaten away my body so that I can't function. It's a horrible, horrible disease, because what is it? Hormones affect every single cell in your body. So there's no particular area that's going to get damaged. It's just completely holistic.
So doing this video today is one way of helping other people hopefully get diagnosed sooner rather than later, so they can alleviate the suffering that they've had as a result of this condition as well. So I find your story to be particularly interesting from that regard, also from some of the things you can learn about what's a normal cortisol level for a person versus what's the normal range, you know. But hopefully there are folks out there who will hear this story and understand that they need to, I wouldn't say push their physicians to make the diagnosis, but suspect this diagnosis, and maybe the physicians will do the proper testing.
Yeah. No, I know a lot of doctors don't like Google medicine, but my experience with this too, through all of the healthcare team that I've had, is that people were willing to listen to my story and not just go with fact. I mean, there were periods where they were just doing labs and stuff like that, but I've had significant points where certain surgeons or certain other healthcare team members would hear it and I'd say, no, I don't think that's right. I mean, you're the doctor and you're telling me all of your wisdom, but I'm telling you my body doesn't, there's something else going on. And finally it clicked with people. So that was important to have.
And I think you're right, too, about it being an underdiagnosed condition. For example, we know that if you look, probably 8% of people with multi-drug resistant hypertension probably have hypercortisolism. 5 to 8% of patients with new onset type 2 diabetes mellitus, and especially type 2 diabetes also with hypertension, probably have hypercortisolism. A proportion of people, probably 7 to 8% with osteoporosis at an early age, same thing, hypercortisolism. We consider these and polycystic ovary syndrome and other features to be gateway diagnoses in patients who don't necessarily look so Cushing weight as you did, but they have these problems as a result of a high cortisol. So these populations should be considered to be screened for abnormal cortisol secretory dynamics. Now, many of these people have adrenal disease, but a fair number have pituitary disease as well. And we see people coming to us for pituitary tumors producing ACTH with all sorts of initial diagnoses that were just classified as, oh, you have high blood pressure, or you have polycystic ovary syndrome, or you have diabetes, or maybe you have them all, but a lot of people have those too. So the treating physicians aren't thinking about the underlying sort of syndrome that ties everything together.
Right.
And that's what we want to encourage people to recognize, is that you may need to have these conversations with your physicians to get to that original diagnosis. And The follow-up on that is when the testing is done, the tests have to be interpreted correctly. Yours were not. I see your results, and it's like, what in the world were they thinking? This was Cushing's years ago.
Yeah.
And so that's another thing we have to educate physicians about, is the actual interpretation of diagnostic tests. First, which tests to do, and then second, how to interpret them, and who to refer to a qualified endocrinologist who can set the diagnosis and get the treatment in motion so that patients can have their suffering alleviated and maybe get a cure, or at least get control, as we have been able to do with you so far.
Yeah, no, I was really lucky. I ran into folks that would think outside the box. Because, it was 6 years, and they just literally just looked at me and said, well, diet and exercise, and take these pills, because now you've got high blood pressure, and now you've got diabetes, and now you've got, heartburn, or kept saying, well, okay, but I don't think it's just fat. It's not just weight gain, There's something odd about all of this. And nobody heard me until I showed up and found a doctor that figured it out.
I'm glad our paths had crossed,
Yeah.
and I really appreciate you participating in this episode of Pituitary Grand Rounds.
Well, thank you
today.
for inviting me, and I hope it helps.
Yeah, I think it will. So it's a great contribution moving forward on your part to help other people.
All right, thanks.
So thanks again.
Yeah.
Thank you for joining us today for this educational program focusing on Cushing's disease in a patient who had a tremendous and remarkable diagnostic and treatment journey. Stay tuned for future episodes. Meanwhile, visit us at www.pituitaryworldnews.org to learn more about this and other conditions that affect patients with pituitary disorders. Thanks, and have a wonderful day.
Thank you for watching. Pituitary World News is a non-profit organization supported by sponsors and people like you. We want to thank you for your support and encourage you to read and listen to the vast content of articles, podcasts, and videos available at pituitaryworldnews.org. Please share this information as widely as you can. Thank you.